Hello everyone and welcome to this lecture about the assessment and management of burns using an A to E approach. So the extent of injury from a burn is best described using the percentage of the total body surface area that's affected by the burn. So the measurement of the burn surface area is the most important during the initial management of people with burns, because this estimates the fluid requirements and determines the need for transfer to a burn service if necessary. And there's several methods that provide a reproducible estimation of the area of the surface area of the burns. But in pre-hospital and emergency department settings, the percentage of the total body surface area burns is more important than the depth of the burn. Okay, and this affects the this determines the severity of the injury, as well as the fluid resource, which we just discussed. So the Wallace rule of nines is very simple, and it's one of the most common burn calculations we use out there. So having a look at this is pretty self-explanatory. You can see it's called the rule of nines because the figures are all broken up into 9, so it's 9% for each arm, for example. So 4.5 at the back, 4.5 at the front. It's 18% for each whole leg, so 9 at the back, 9 at the front. And the trunk as well is 18, so the top is 9 and the bottom is 9 at the back, and at the front we can split that up as well, 9 and 9, but the full trunk, so front and back, would be 18 and 18, so 36%. Let me just delete this here so you can see better. Okay, so the exception is the perineum, which is 1% here. And hands, including fingers, is also 1%. So pediatrics, we use different percentages for pediatrics because the surface area on the head and the neck, relative to the surface area of the limbs, is typically higher in children than in adults. So this is a little bit harder to remember than the rule of nines, because there are different numbers here, but you will often see these pediatric burn assessments. You'll have them in front of you if you do work in a unit that cares for pediatric burns, or in the emergency department as well. And they're also age specific, so age 0, 1, 5, 10, 15, and you can see the changes in the percentages there. And then you would have this, you have a form here to calculate the percentage for the pediatric. So how do we respond to a patient presenting with a burn? Well, as with any emergency, we need to use the emergency principles of care, which are to remove them from danger, to stop the burning, obviously remove ourselves from danger as well, and then we need to assess our patients using an A to E approach. Okay. So first, in the A to E algorithm, we need to protect our patient's airway, and we do that with C-spine protection. So the patient's airway is at significant risk in severe burn injuries, as you can see here. So when there's involvement of facial or inhalation injuries, you've always got to suspect that the airway may be involved. It's very important to quickly identify those who may require intubation early. We must stabilise their airway as soon as possible. So we need to do that because the swelling and the edema can rapidly progress, and the airway can in effect close over. So we need to intubate them as soon as we can. So we need to assess for any inhalation injury. So has there been any history of exposure to fire and smoke in an enclosed setting? Are there any changes to the voice? Is the voice hoarse or higher than usual? Is there a harsh cough? Any burns to the face, head and neck swelling, singed nasal hair, eyebrows or eyelashes could all indicate an inhalation injury. So if need be, we'd need to attempt simple airway manoeuvres. And we can open the airway using chin lift and jaw thrust. And we can suction the airway if there's any excessive secretions or if there's any soot in the airway or if the patient's unable to clear their airway independently. And in this situation, if we're the first responder on the scene, we may need to insert an oropharyngeal or a nasopharyngeal airway. So moving on to breathing, the immediate care around breathing. So what do? We assess the chest. We count the respiratory rate. If there's an elevated respiratory rate, it could be a marker of potential inhalation injury as well. It could be a early warning that the patient may deteriorate and they may go on to do so quite rapidly. So as well as the rate of breathing, we also need to note the depth and the pattern of respiration and assess the symmetry and rise and fall of the chest. So remember that there's underlying chest injuries that may also be present in addition to the burn. So we need to do a respiratory assessment and we need to assess for any wheeze, any stridor, any decreased air entry. And remember that if we're looking at the chest, any circumferential burns, those are the burns that go around the chest, they can inhibit the chest wall expansion and make ventilation very difficult. So in that case, we'd need to consider an escherotomy, which we'll discuss below. So we also need to record the oxygen saturation and administer oxygen if need be. Now it's important to know when measuring the oxygen saturation that it can still be a normal level if the patient has carbon monoxide poisoning, and that's because carbon monoxide preferentially binds to hemoglobin, so that gives us a false measurement of oxygen saturation levels. So oxygen administration needs to take place regardless of the oxygen saturation recording, and we should assume carbon monoxide poisoning in patients who sustain burns in enclosed areas. So this is what an escherotomy looks like. It's not very pretty, as you can see, but due to the burns here, this would have inhibited, if the escherotomy wasn't performed, it would have impeded the rise and fall of the chest and affected ventilation. So what the escherotomy does is, as you can see, there's many cuts placed in this really dense, thick, leathery tissue. So, we're assuming these are full thickness burns here. And that just allows for movement of the chest wall there so we can ventilate properly. And it's not just for breathing, we can do it in arm wounds here, as you can see, in limbs as well, and that's to prevent compartment syndrome. So moving on to circulation. So we need to assess circulation and perfusion in our patients, in our burns patients. So we would check the heart rate, blood pressure, and we'd have a look at the neck veins for any distension as well. So we can inspect for any signs of hemorrhage if they've been involved in an injury as well as the burn, and apply direct pressure to any external wounds that we can see. So we need to consider the potential for any significant internal bleeding depending on the mechanism of injury, if there has been an injury involved as well as the burn, because this could lead to symptoms of shock. Now, our patients with burns will lose fluid rapidly, so we need to insert 2 large bore peripheral IV cannulas, preferably through non-burnt tissue if that's possible. But if access is difficult, we'd need to consider central access or intraosseous, which is a needle into the bone, if that's available. And we need to be commencing fluid resus as soon as possible in patients that have burns greater than 20% total body surface area. We need to monitor the circulation of the peripheries in the trunk so we can do capillary refill time to assess what the circulation is like and have a look at the skin colour as well. Because poor perfusion may indicate the need to perform debridement of the area. So thinking about assessing and caring from our patients from a disability perspective. So we need to assess the level of consciousness. Are they conscious? We can use the GCS and the AVPU scale. This is going to give us our baseline for care. So the AVPU scale, A relates to alert, V stands for voice, P for pain, U unresponsive. And inadequate oxygenation as well as inhalation of smoke and toxins may lead to a decreased level of consciousness, especially in severe burns. And we also need to check the pupillary response and the blood glucose level as well. And this ensures that any alterations in the level of consciousness aren't related to a metabolic cause. Now, patients presenting with burns may be in severe pain, so we need to make sure that we are giving them adequate pain relief. It's highly likely if they have a severe burn that they will need morphine. So from an exposure perspective in the A to E assessment, we need to be removing the patient's clothing and any jewellery in order to prevent any further heat injury, and to be able to fully assess all areas of the body. In suspected chemical burns, clothing may remain contaminated, so we need to protect ourselves and handle any of their clothing appropriately, wearing correct PPE. Because inappropriate handling may also expose the patient to further injury as well as the care provider. And it's important to minimise heat loss for severe burns patients due to the risk of hypothermia, secondary to the loss of skin integrity. So we've lost that layer of skin that's keeping the heat inside our bodies, so they're obviously at a higher risk of hypothermia. So it's really important to monitor the patient's temperature and keep them in a warm environment with warm IV fluids if possible. Now, after our A to E assessment, we move on to the secondary survey. And the secondary survey is only going to be commenced once the primary survey has been completed and any life-threatening injuries have been treated. If during the examination any deterioration is detected, then you've got to go back and start from A and then go through to E again. So you keep doing your primary survey over and over again until your patient's stable. So when it comes to secondary survey, we need to be taking a thorough history from our patients, bystanders or any emergency personnel who were there, of the events surrounding the injury, because this can assist with understanding the extent of the injury, the likelihood of inhalation burns and any possible other injuries as well. So it's useful to use an acronym. So the AMPLE acronym is very useful to establish a comprehensive history. So the AMPLE acronym will find out about any allergies the patient may have, what medications they're currently taking or if they've taken any, what their past medical history is, including tetanus status, when they had something to eat last, and any events leading to the injury. It's also important to know what first aid may have already been given to the patient, and then to perform a head-to-toe examination, literally from the scalp to the toes, and this is to identify any other injuries that haven't been identified already. And one of the most important elements of the secondary survey is measuring the burn, so calculating the total body surface area burnt, because we need to use that figure for any fluid resource if need be, and classifying the burn as well. So we need to assess the depth of the burn. Okay, now so thinking about the immediate care of the burn injury management, the aim of wound care really is to reduce the chance of infection and also to promote healing. And there's many different types of dressings, and each classification of burn would require a different type of dressings, and they're very complex. So if in doubt, it's best to contact a specialist burns nurse who will be able to advise of the correct dressing or ointment to use if need be. Now, for severe burns, skin grafts may need to be used. And we're very lucky in WA to have one of the world's leading burn specialists work here. She's an incredible woman called Dr. Fiona Wood, and her goal is to enable scarless wound healing following a burn. She's actually developed a spray-on skin where a patient's own skin cells are grown in a lab over the course of a few days, and then they're turned into a spray form and literally sprayed onto the skin. Absolutely incredible work that she's doing. It's going to be amazing to see how her work develops in the future. Now here is a great example. You can print this off if you like, and there's also a link to it in the references. But this goes through the different types of dressing that can be used depending on the type of burn. And this is very, very useful, but again, especially as a new grad nurse, if you are struggling or you're not quite sure, just give the burns specialist a call. They can often give you some advice if you send them a picture, or if you're in a large tertiary hospital, they'll pop down and assess the patient for you. I hope you enjoyed this lecture. There's lots of references here for you to have a look through, and more information if you would like. Thank you for listening.